Nankishore, are we live?
Just 20 seconds, sir.
Okay.
We are live, sir.
Great. So, good evening, everyone, and welcome to another episode of Welcome to NetConnect. So, NetConnect is basically a new initiative that we've started from Genova, where we discuss the challenging and unusual cases in the field of neuroendocrine tumors. And before we begin, let's just give a small brief introduction regarding what is Genova. So, we are basically a biotherapeutic organization where in the last 10 years we've touched thousands of lives, but in the coming 10 more years we want to touch millions. So we aspire to transform the healthcare of millions of people, especially through implementation of technological solutions, and in the process be the top 10 technologically driven companies in the world. We are currently based at Pune, and as I said, it's a biotech company in the business of transforming healthcare. What do we do? So we basically manufacture biotherapeutics. How do we do that? We innovate biomanufacturing technologies, and the entire goal is to transform healthcare, and that's how we are going to do the same. It's been an exciting journey for us. We've established Genova in 2006, and since then we have launched various molecules like Vintor, Elaxim, Mgrast, Pegex, also Tenectase, Hamsil, etc., etc. Even during the COVID times, we had the Gemcovac 19 COVID vaccine as well, which was developed. And recently, last year, we have launched Hamsil Junior for pediatric cancers. So we are currently in stroke care management, mRNA vaccines and biotherapeutics, cancer care management, and apart from that, also in cardiac care, renal management, ophthalmology, etc. And a lot of other research is currently going on. So with this, without further ado, it's a pleasure to invite our moderator and speaker for today, Dr. Indranil Ghosh. Definitely doesn't require any introduction from our end. He's a well-renowned medical oncologist at the Apollo Hospital, Kolkata. Sir, we are very lucky to have you here today. So welcome for this NetConnect meeting, sir. With this, we also have an esteemed panel with us here today. Dr. Arun Warrior from Cochin, Dr. Deepak Bharti from Jammu, Dr. Ekta from Ahmedabad, Dr. Hanisha from Guntur, Dr. Mohammad Soil from Lucknow, Dr. Rohit Pai from Mumbai, Dr. Bagmar from Faridabad, Dr. Shripad from Sambhajinagar, and Dr. Unni Pillai from Kottayam. So we welcome our esteemed panel as well for this NetConnect meeting today. And without further ado, I'll hand the stage over to Dr. Indranil Ghosh. Sir, over to you.
Thank you, Dr. Ronak. Thanks for giving me this opportunity. We really have a very enlightened panel today. From north to south and from east to west, we have not left any corners. So hope we will have some interesting discussion.
Right, sir.
My first job was to present challenging and unusual cases on NET. I will present two cases. I don't think these are unusual, but challenging nevertheless, at least in some phases. So let's see.
Yes, sir, we can see your screen. Yeah, perfect. Please go ahead.
The first patient, a 49-year-old lady with no known comorbidities, presented with complaints of intermittent pain in the central abdomen with vomiting for 1 week. There has been some history of weight loss significant over the last 2 months. This was in 2019 December. So he underwent a CCT whole abdomen. We showed ill-defined nodular lesion in jejunal mesentery, extending up to jejunal loops, and few nodular lesions in segment 4, 6, and 7 of liver query carcinoid. Upper GI and colonoscopy were normal essentially. Soon after that, she was admitted with acute abdominal pain and vomiting with symptoms of small bowel obstruction. A PET CT was done. It was a FDG PET CT only uh, on 1st January 2020, intensely enhancing FDG avid mass in short segment of distal jejunum with periserosal extension and infiltration and desmoplastic reaction in the adjacent mesentery with enlarging FDG avid mesenteric lymph node causing subacute intestinal obstruction and multiple focal enhancing FDG non-avid lesions in the liver. In triple phase contrast study, these nodules show features of metastatic nodules. Because of the intestinal obstruction, under laparotomy and resection anastomosis of jejunum under general anesthesia on 9 January. Intra, they found extensive bilateral liver metastasis and a complex mass involving small intestine, distal jejunum and ileum, continuous with the mesenteric mass, infiltrating retroperitoneum and encasing SMA and SMV at the root of mesentery. And a segment of ischemic bowel was there in the jejunum. Histopath showed a small gut, well-differentiated neuroendocrine tumor, 2.5 centimeter, grade 1, PT3N0, margins free, no lymph node metastasis. After that, patient slowly recovered. The obstructive symptoms were gone. Gradually, enteral nutrition started. From February, she was started on octreotide depot, 30 mg monthly. CT scan serially have been showing stable disease. If you see, sometimes there has been some reduction in the jejunal mass and few the liver mets were essentially stable. So this is the last CT scan, May 2025. It is still stable and octreotide is going on. So this is just showing a very good response to octreotide, even though the patient was very much sick at the onset with intestinal obstruction, ischemia, bowel ischemia and all, and multiple liver mets are there. But with therapy, more than 5 years, she is fully active and no symptoms are there right now. Second case, she is also 60-year-old lady, type 2 diabetes and hypertension with comorbidities. 2021 July, she presented with persistent diarrhea, abdominal pain, and weight loss. So that's the other kind of presentation. That was obstruction. This was diarrhea. She underwent a colonoscopy to find out the cause and had a colonic perforation, for which underwent emergency laparotomy and stoma, ileostomy. Histopath, the biopsy was taken from the deposit, peritoneal deposit, which showed metastatic NET grade 2, possibly of small bowel origin. And then she underwent Dotanoc PET CT in September, which showed duodenal primary lesion, multiple abdominal nodes, hepatic, skeletal, and peritoneal mets. Octreotide depot again was started for this patient also from September 2021. In January 2022, the first re-evaluation showed a stable disease. Similarly, July 22 and February 23 also it was stable disease. In July 2023, so it was almost 2 years after starting the therapy, it showed partial metabolic response. However, in January 2024, the duodenal lesion increased and there were new DOTA-avid lymph node and visceral lesions suggestive of progressive metabolic disease. Everolimus, she was counseled for PRRT, but there were some logistic issues initially. So everolimus was added to octreotide as of breach therapy. These are the chromogranins, not much significant, 30 and 24. Finally, the PRRT could be arranged from 4th April 2024. Everolimus was stopped before that. Octreotide depot was given 2 weeks after PRRT. So 2 weeks before and 2 weeks after PRRT, octreotide was stopped. Octreotide depot. In between, also she had diarrhea, so that was managed by short-acting octreotide. She always had these diarrheal symptoms which were persistent, even though the disease was stable and there was a partial metabolic response also at some point. Second PRRT was done in June 2024. After that, Dotapate in August showed partial response. Third and fourth PRRT were done in September and November respectively. In January, Dotapate showed significant partial response. The fifth PRRT, fifth and sixth were done in March and May this year. After that, in July, Dotapate showed complete disappearance of expression in liver lesion and omental nodules. Also in the internal memory node, and the rest were basically same. So it was a partial response. Currently, she is again maintained on octreotide depot. It has been restarted in August. After the it was continuing. I think after the sixth PRRT from June, it was restarted and still continuing. So that was for the cases. So if there are any questions, we can take or we can move to the panel.
Sir, I guess we can move to the panel.
Okay. So we have a few questions which we will learn from each of you regarding your experience and your opinion. What are the most common presenting symptoms of NET in your clinical practice? We'll start with Dr. Unni.
Hi, I hope I'm audible.
Yeah.
Yeah. So, that depends upon where is your tumor, and also to some extent whether your tumor is hormone secreting or not. Most often, you have a pancreatic NET, and you'll have all the abdominal symptoms: pain, bloating, and all some
45
various.
You are not speaking.
So, you will get all the abdominal symptoms when you have a pancreatic NET, dyspepsia, loss of appetite, distension, pain, etc. So it varies, depends upon where exactly you have the tumor and also whether your tumor is hormone secreting or not. You also can get an incidental finding when you do a scans. You find incidentally multiple liver lesions, and when you evaluate, you may sometimes find a low-grade NET. That is also we have seen. So
Okay. So if I were to say in how many, what proportion your patient presents with local symptoms, and in what proportion they have, this paraneoplastic syndrome?
paraneoplastic syndromes are very less. Around 10 to 20% of them will have that carcinoid syndrome. I have seen probably 4 or 5 in my lifetime. I mean, in my recent times, or, but most of them will have, local symptoms or symptoms due to metastatic disease. The paraneoplastic symptoms most commonly occur when your patient has some of the syndromic NETs, like you have a MEN syndrome associated NET, or you have a Solinger-Ellison syndrome kind of syndrome. presentation, you'll have a lot of hormone-associated symptoms. Your carcinoid symptom per se is very rare. Most of them will have local or loco-regional symptoms or symptoms due to metastasis.
Oh, thank you. Dr. Deepak.
Yes, good evening, sir.
Yeah, good evening.
So there are two things we have to be very precision. It all depends on what site is involved. It can start from a simple acidity and dyspepsia to obstruction, as the cases all the representatives there. So majorly, I think most of our patients came to us in our practice and were diagnosed. Is I think incidental findings are there. It's not. I think that majorly are coming with some major symptom. It's just the routine investigation of doing some ultrasonography or some CT scan other way around that we are finding these some suspicious net findings. And there are certain chunk of patients, 30-40%, which are presenting in either in emergency or in elective OPD patients only. So there are two way rounds. Either elective OPD with some incidental findings or some serious emergencies landing up in the all the way starting from this hematemesis, obstruction, this all the factors can be there. So I think it's majorly site oriented and regarding the as other colleagues is telling the things that I find that majority of patients are coming to a group with some non-specific symptoms. With specific symptoms, the percentage I will just show from 70 to 30%. 70% are non-specific, 30% are specific symptoms for the disease related.
Right. Dr. Ekta, your views on this, please.
I think, sir, I'm agree with others that majority, not all the patients they have some symptoms. They are found incidentally, and majority patients they have some local symptoms and secretory symptoms. I saw very less in my practice.
Right. So most of the time we are not having any secretory or paraneoplastic syndrome. Some patients do have. Even carcinoid heart disease also happens sometimes. It is rare, but it happens. Um, so yes. Next slide, please. How often do you use biochemical markers like chromogranin A, 5-HIA, or pancreastatin in diagnosis? Dr. Safalta?
Good evening, sir. Good to see you after a long time.
Yeah, same here.
Uh, so I do chromogranin 5-HIAA at the baseline, and chromogranin I do in follow-ups. So I don't repeat 5-HIAA as frequently, or pancreastatin I haven't done yet, both in diagnosis as well as in follow-up. Yeah.
So how useful is this chromogranin for follow-up?
So chromogranin is not it's not required for the diagnosis per se, because it has been taken out from the diagnosis part. But follow-up, yes, it is. So every time you cannot do DOTA if the patient is asymptomatic and not have, and then I don't do it, and I don't do any of the marker. If at all, after 3 months or after 6 months of say, I don't want to do DOTA PET as frequently, then in that case I do chromogranin and just do the follow-up. That's how. So to
Yes, how often it is useful? Because many times I find that chromogranin is rising, then we do a scan, it is stable. So, and the chromogranin also is not a cheap test. So,
yes.
clinically, is it useful? According to you, it is, right?
So whenever a patient who presents with mild symptoms, in that case, what I do before doing a DOTA PET, I do a chromogranin. If at all it is like rising trend, then I repeat DOTA PET. That's how I do. So it is not a very good marker, but then this is how I do the testing.
Okay, good. Dr. Suhel? Dr. Suhel, are you there? Probably not. Dr. Arun?
Yeah, so I think
Yes,
with
sir, I'm here, sir.
yeah, please,
Yeah, go ahead,
Dr.
please.
Suhail, please.
Yes, sir. Okay, good evening, sir. Sir, I usually do chromogranin at baseline if the patient is having symptoms of secretory anity. But we usually don't do, we also do in follow-ups, but since it is having high, it does not have high specificity. So we usually avoid doing in baseline, but we are doing it in follow-up cases, sir.
Okay. So basically same as Dr. Safalta. Dr. Arun, do you have any other experience?
No, I think the DOTA is definitely much more easier to do. At baseline, I may do a chromogranin A. After that, the follow with scans only, functional imaging only. I won't repeat.
Okay, thank you. Next slide. Okay, what is your approach to identifying the primary site in cases of NETs of unknown origin? Dr. Hanisha?
Like in any other tumors of unknown origin, primary of unknown origin, I would like to get an imaging done first. If it is grade 1 and grade 2, well differentiated NETs, then it would be somatostatin receptor scintigraphy like DOTANOC or DOTATATE, whichever is available. Gallium, we usually do gallium DOTATATE in our center. So then, if it is grade 3, then I would like to go ahead with either FTG PET or FAPI PET, which both are available at our center. And then the scopy being, we can also, depending on the site, the suspected site, we can go ahead with the either upper GI scopy or lower GI scopy or bronchoscopy if it is NET of the lung, if the suspicion is NET lung.
Right. So I think it will be pretty much the same for all. Still, Dr. Rohit?
So there are certain like upper GI endoscopy and lower GI endoscopy can be done. Then one thing, if you don't get anything, it can be in the small intestine also where you cannot do the scopies. In
Yeah.
that case, if a patient is presented with a mesenteric mass, then in that case you can go ahead with the video endoscopy so that you find out whether it is there. Because mid-gut NETs they present as mesenteric mass also. And if at all it is not feasible, then in that case, in biopsy, also there are like PTF1 is positive in patients who are having NET from lung. Then ISL1 is positive in pancreatic NETs. So that's how with through IHCs this can be differentiated.
Yeah, very good pointers. Dr. Rohit? Dr. Rohit, are you there? No. Dr. Shripad? I don't think Dr. Shripad and Dr. Rohit have joined.
Dr. Rohit has just joined.
Yes, Dr. Rohit. Can you hear me?
Yes, sir.
Yeah, so if a patient comes to you with a NET liver mets biopsy done in a NET low grade, so what is your approach to identify the primary site?
So I would consider doing a Rotanok PET scan,
Yeah,
and Rotanok PET scan should be able to provide most of the answers. If it is NET low grade, it will be Rota Avid, and then I think I can go for the appropriate investigation, including endoscopy and a biopsy.
okay, thank you. Next slide, please. At what stage of NETs do you typically initiate octreotide therapy? So I will just modify the question. So do you only give it for unresectable or metastatic cases or sometimes for adjuvant therapy as well? Dr.
So the
Deepak?
question is for me.
Yeah, you can answer if you want. No.
So there is no data for adjuvant octreotide after completely resected low grade NET. So usually it is for secretory patients who are having secretory symptoms or as a measure to sort of stabilize the growth in advanced cases.
Right. Dr.
I
Deepak?
just want, yes, sir. So, sir, basically, I just want to give certain clarity for the last question because we know majority of the cups or the certain things endo colon whatever you can do, we are still not able to get the diagnosis of all the things. I think ISC is the way forward for that thing. For the different sites, there are different ISC markers are there. by the way we can differentiate. This is very important in that case. And as this case we are giving only in the unstructured or metastatic setting only, I'm not using in adjuvant setting till now.
Anybody has used in adjuvant setting? Very high risk patient, multiple nodes positive after dissection? No.
Sir, I have used it.
If it's R1, if it's R2 section, then we can obviously we have to give the thing. If it is R0, and we don't have to.
Yeah, R0 only I am talking about. R2 is a different thing. Okay. Next slide, please. What factors influence your choice between octreotide and lanreotide? Is lanreotide available here?
No.
Anybody used lanreotide?
No.
No. So let me pose a
No.
different question. Do you start with a short-acting octreotide and later switch to the long-acting, or give directly long-acting?
No. Long,
Long
report. Operator report is the always. That is the choice.
Long-acting upfront.
Yeah.
Yeah.
Would I have not seen. Okay. So Indranil sir.
Yeah.
Rohit here, Rohit Pai.
Yeah.
So in case there is octreotide crisis, the long-acting octreotide does take a week or two to act. So I think we'll need to sort of start with the short-acting one and overlap it with the long-acting one. That would be a prudent.
Yeah. So if there is a lot of secretory symptoms, we might try to control it with short-acting and give the long-acting parallelly like that. Thank you. So next slide, please. What long-term benefits have you observed in patients maintained on octreotide therapy? No, it's a very broad question. So let me pose it differently. So if you start a patient on octreotide in a metastatic NET grade 1 or 2, how much PFS do you expect upfront? Dr. Ekta?
For NET grade 1 or 2.
Yeah.
So I think majority of the times we see stable disease with octreotide therapy. And if it is lower grade, then we see the longer PFS.
Till how long you have to see in your experience?
I
Average.
think in grade 1, it is probably 1 to 2 years.
No, ma'am. There are many patients who survive many years on octreotide. Low grade NET survive many years. We have patients up to 15, 16 years on octreotide on our center. Regularly on octreotide, no progression. We have a patient who is on octreotide for 16 years, duodenal NET with the liver mets. And many of our patients do really well if they're low grade, especially if their K60 is close to, less than around 5% or so, or less than 5%, they do extremely well. So your short survival happens when your K67 is high, or you have a high grade NET. Low grade NET is really good. Some of them even may not, even if the metastatic disease with a low K67 with a low disease burden, asymptomatic patient can be kept on follow observation, and you can treat when they are symptomatic. So they are just low grade NETs are superbly treatment sensitive, very good disease even in the metastatic setting.
Right. So many patients do remain stable for a longer time. Dr. Hanisha, what's your experience?
Patients do well if it is well differentiated on octreotide. They do well. So the symptoms are well controlled. They are there for many years, like Sir has already mentioned, like my other colleagues have mentioned. So I think in the PROMIT trial in which octreotide was there versus placebo, it was the overall survival was approximately 84 months of OS benefit was there. And the PFS was approximately up to 2 years, the progression-free survival.
Yeah. Thank you. So next slide, please. How do you integrate PRRT with octreotide therapy? I know I discussed this in one of the cases, but we will hear from the experts as well. Dr. Arun?
So I think whether to do PRRT upfront is a hot debate even in the nuclear medicine circles. So in our center, she prefers not to do it upfront. Our nuclear medicine specialist waits, and when they progress, only they do. So there are people who do upfront, and then people who do later also. We follow the later approach, and I found it useful.
So if the patient on octreotide progresses and starts PRRT, will you continue the octreotide or not?
Yeah, octreotide has to be given even when we give chemo also that it's like a backbone that I understood that to continue.
But
Anyway, the 2 weeks break is needed, like you told.
interval,
That washout period is needed. Correct.
yeah, that is the usual practice. Though I will come back to it. Let's hear from some of the other experts. Dr. Safalta?
So PRRT, the NETConnect trial, it is PRRT can be used upfront in grade 2 NET. So in grade 1, what I do is I continue with the octreotide, and whenever there is a progression, if it is mild progression, I may consider of increasing the octreotide also, like 40 mg. But then if it is there is still more progression, then in that case I use PRRT. In grade 2 NET, then it has shown that integrating PRRT upfront along with the octreotide, it has shown a benefit, PFS benefit. So I do consider it in the patients who are having large volume disease.
Okay, and you do continue octreotide during PRRT?
Yes, octreotide is to be given. Yes. And it is what I have like read in the study, as well as I have been practicing, it is like 1 month of gap, and that is also practice in our center, that there should be 1 month gap. So you give 1 month gap, just 4 weeks gap, you do PRRT, and just after that, in fact, within 2-3 days also you can give sandostatin.
Okay.
So correct me if I'm wrong, if it is.
There is no correct answer. I was saying that only because this has not been studied well. So these are some of the expert opinion are there 2 weeks, 4 weeks, at least 2 weeks after in somewhere I read at least doing the PRIT, wait for 2 weeks, with the next one, then automatically you are getting a 4 weeks gap before the next PRIT. So like that.
Yes.
These are just expert opinion, no randomized or any great data. Next slide, please. How do you manage patients with functional iniquities and hormone-related symptoms? Dr. Suel?
So for these patients who are having functional entities and symptoms are there, so we can give short-acting octreotide, and after the symptoms are controlled, we can shift the patient to the long-acting one, sir.
Okay. Dr. Rohit? Functional entities? Dr. Rohini?
Functional entities, if it's a diarrhea related symptoms, they do respond to short acting or low dose, the short acting octreotide. But you have to start long acting octreotide side by side. So most of the time your symptoms do happen when there are large liver mets or something like that. The best way to control the symptoms is to control the disease itself. So most of the time, the symptoms happen when you treat the patient on long-acting octreotide. When your disease progresses, you do get symptoms, and then you have to control those with, you need to either give PRRT or you need to add everolimus or sunitinib to control that. Upfront, you are getting a, carcinoid syndrome is very, very rare, basically. They'll have mild symptoms or something, unless you get someone with profuse diarrhea, wherein you need to use, your short-acting octreotide. Otherwise, most of them will be fit for long-acting octreotide. That's my experience. I am yet to come across with anything other than this in my practice, but there could be exceptions. My symptomatic, hormone-related symptoms happen when the patient is having extensive liver mets, and someone who has progressed on usual octreotide,
Okay.
long acting.
In any patient, you have to increase the dose of octreotide, long acting, just to control the hormone-related symptoms.
Excuse me, sir, I didn't get you.
In any patient, suppose with hormone-related symptoms, you started on 30 mg monthly, and after that, that was not sufficient, and you have to increase it to 40 or
Yeah,
50.
we have to increase up to 60. Yeah, that's
Okay.
a good option, sir.
Okay. Dr. Ekta, your experience on these functional symptoms? Dr. Ekta is here, I think. Dr. Hanisha?
I agree with the other panelists regarding diarrhea. Like we use loperamide also in addition to sandostatin or short-acting octreotide. Then we got antihistamines for flushing. If the patient is having flushing or itching, then we can use antihistamines. And then we can suggest dietary restrictions like to avoid cheese, if it is carcinoid, and to avoid cheese and alcohol.
Right. Thank you. So next slide, please. This part we have covered already, the monitoring regarding chromogranin and Totanox scan. We are not going into that again. Next slide, please. Do you use everolimus or sunitinib in combination with octreotide, and if so, for which scenario? Dr. Arun?
So sunitinib I have not tried. So generally they are reserved after chemo. So it's a captum is the usual thing once I progress on octreotide. Then later only I may go for everolimus. Not used sunitinib.
Sunitinib only for pancreas, or we have used for GIT
No,
also?
sunitinib I not give. I not given in any scenarios. Only everolimus I give.
Yeah. So which one works better, everolimus or Captem, in your experience?
No, I think captain is what we give first. Then once they progress, we give everolimus. So basically, it's a bad disease. So definitely, then the response are not that great with everolimus. So,
Absolutely. Dr.
So,
Safalta?
everolimus I give in the grade 2 NETs when the Ki67 is less than 45%. If it is more than 45%, then I switch over to Captem. Sorry, 55%. And then if it is poorly differentiated, then only I go towards other chemotherapy. Otherwise, in grade 3 NETs, Captem I use. In grade 2, everolimus is my first choice.
So have you used Captem in grade 1 and 2?
No.
No.
No, sir. No.
So after everolimus and progression, patient not okay for going for
PRRT. PRRT is one option. Cabozantinib is another option.
Okay. Anyone used Captem more?
So
That, that
sorry.
is for neuroendocrine carcinoma, sir, not for neuroendocrine tumor. So
So
the evidence for capecitabine plus temozolomide is for neuroendocrine carcinoma, not for usual low-grade neuroendocrine tumor.
So actually, the evidence for capnum is not for neuroendocrine carcinoma. It is for neuroendocrine tumors high grade. A neuroendocrine carcinoma is more than 60% Ki67. They are treated with carboplatin etoposide. But high grade neuroendocrine tumors, probably in the range of more than 10% up to 60% neuroendocrine tumors, grade 3, are treated with captem, and that is something which we may consider in certain patients.
Yeah, I would agree that neuroendocrine carcinoma is different thing. So as Dr. Sapalta mentioned, neuroendocrine but higher grade, neuroendocrine tumor but higher grade, Captem is better. But many times we end up using Captem in the lower grade also. And it
I think
helps.
again with the combined FDG PET and DOTA scans coming up now, this grading thing, whether we should really focus or this combined scans will help us in guiding management, because that I have found useful to do the combined FDG and DOTA scans. Any opinions on that?
You will find that you'll be able to find out more of the high grade tumors if they are also FTG of it. The low grade tumors will be usually FTG, may not be taking that much and will be very much DOTA of it.
So exactly, that's where the captum may work also. That's it.
So whenever the Ki-67 is high, probably you use for captum, and for small cell you use cisplatin or carboplatin reposide without atezolizumab. So that's a neuroendocrine tumor is a spectrum. From one end you have very low grade neuroendocrine tumor, and on the other side you have a frank small cell kind of carcinoma. So it's a spectrum, and where your patients fit into, that decide what kind of regimen.
No, exactly. That's what Dr. Puney was asking, because this key and all are static things, not like a diagnosis we do, but the other ones are more dynamic functional imaging. So whether what is the opinion of the general panel about the combined scans, combined functional modality? That's my question.
Anyone used combined scan?
Combined scan, I generally do at the starting. I generally ask for that combination, and once I progress also, that is two areas where I have found it useful. Combination of two.
Dr. Safalta, you do scans? No.
Yes, combined scan, especially when it is grade 2, and even in grade 1, if there is extensive disease, then I do PET scan as well. And I have find in many patients that there are certain islands which are showing more FDG avidity as compared to DOTA PET. So it is like grade 1, grade 2, they can coexist. So like, it should be done actually, just to find out whether there is any component of the higher grade NETs or in patients.
Whenever if we suspect a higher grade progression, then we can do combine. Dr. Deepak, experienced with everolimus?
So basically, we all start with the Sandostatin other way around. And in the second line, I definitely shift to the everolimus. It is just the if some disease is less than 30%, I will start with everolimus, and if anything is more than 30%, I will start with Captam. And regarding everolimus, in majority of patients, I'm not able to give more than 5 mg, and 25 patients are there, we can tolerate full dose of 10 mg. That can also make a difference, but initially we start with 5 mg only, and if a patient is showing clinical and radiology response, that is okay. Otherwise, I will have to increase as per the susceptibility of the patient. And there are certain patients who are long time survivors or everolimus only, and we have certain patients for that extent. With the event of that cabozantinib and other way around, obviously we have a lighter options and better efficacy ones also. And I think in coming times we can shift from everolimus to cabozantinib also, as it's a category 1 recognition also. But till now I'm using this sandostatin followed by everolimus if its Ki is less than 30. If more than 30, then I shift to Captam.
I think,
One
sir,
more thing to add. Uh,
Yeah.
so everolimus in Radiant 4 study, non-functional entities were included. So if a patient who is having functional entities and you want to add some other agent, in that case, PRRT would be the first choice. And in non-functional, it will be everolimus.
I do agree with madam. So what I usually, in our practice, someone has responded very well on octreotide and they have slow progression, then adding everolimus to the octreotide will yield a very good result. But if your patient is progressing very fast, then probably everolimus may not be of any use. So as Dr. Safalta said, whenever the patient progresses on octreotide, I think the best way to go forward as of now is to add PRRT. And when the patient progresses after PRRT and then it's a slow progression or minimal progression, then probably everolimus octreotide can give you fantastic result. But if you have a hyper progression, then probably you're looking at a high grade tumor, and probably you need to give off a Captam or some of the chemotherapy regimen also.
Yeah, everolimus is not known to cause too much objective responses, mostly stable disease. So, yeah. Next slide. So there's a biochemical progression, but imaging is stable.
We don't do anything, sir. So
yeah, we discussed
most of the time that is a fallacy of doing the chromogranin. The chromogranin, especially at lower levels of chromogranin, you may see minimal fluctuation every time. So if you follow up the chromogranin closely, you may really see fluctuating chromogranin levels. But Anything like doubling your chromogranin, tripling your chromogranin is really problematic. You need to do an imaging. But otherwise, minimal fluctuation, we need not have to do, and we can continue that.
Yeah, I think this is the next slide. What is your approach to discontinuing or de-escalating therapy in long-term responders? I don't think anybody will do that.
No, no risk,
No,
no,
no.
no experience.
Like intermittent ADT, you give intermittent acute.
No evidence, sir.
Yeah. Next slide. Yeah, so
Thank
that's
you.
so the organizers, if you have any questions, you can put forward to the panel.
No, sir, we don't have any questions in the chat box as well.
Okay, I would like to thank all the panelists for a very exciting discussion. We all learned a lot, and I think the organizers will also be benefited. Thank you again.
Thank you, sir. Thank you.
Thank you, sir.
Thank you so much, sir.
Thank you. Bye bye.
Thank you.
Bye, bye, sir. Bye.
Sure, we can end today's. ठीक है चलो साइली लॉगिंग ऑफ
Done.